Good morning. My name is LeSiege. I'm a physician assistant here at Milford Regional Medical Center. And today I'm going to give a brief talk about smoking and some of the smoking cessation modalities that would be available to people that are trying to quit. So I'd like to start by talking about a brief history of smoking. Tobacco has been growing in the Americas for over 8,000 years, and it really was used first as a monetary standard, quickly developing throughout the 15 and 1600s. And by the 1700s, smoking had become widespread, and the tobacco industry itself had widely developed. The second wave of tobacco growth and development really took place between the 1800s and 1900s. And some of the things that really helped to really develop the tobacco industry was the development of the cigarette machine, the development of the match, and of course the completion of railroads throughout the country allowed for rapid distribution throughout the United States. Of course, R.J. Reynolds became the first company to really develop the tobacco industry in the early 1900s, developing their only brand at that time. And this quickly led to other companies developing their brands. And they enjoyed success through extensive marketing, particularly to women during that time period. The next wave really came in the early 20th century when some of the early recognition of the health risks of tobacco use came to fruition. And despite these known risks, extensive marketing continued through the tobacco companies to encourage people to continue smoking. Really the tobacco companies and their aggressive marketing is what really got people involved in smoking. It became socially acceptable. It wasn't until 1998 through 2006 where there was a significant resurgence in other tobacco products like smokeless tobacco, largely in part due to changing of the indoor smoking laws. It wasn't really until 2009 when the FDA regulated tobacco for the first time, and the U.S. Supreme Court allowed for more aggressive labeling on cigarette containers. Then came along the electronic cigarette, or well known today as a vape. That really took place in 2005 and brought us back to some of the earlier days of early cigarette use. The FDA did extend its power to regulate e-cigarettes and ban its access to minors in 2016. And while we're on the topic, this frequently comes up in smoking talks, is, what is an e-cigarette or a vape? It really is an electronic form of a cigarette. It delivers nicotine, but it is not harmless. It does have ultrafine particles. There are flavorings such as diacetyl, which is a chemical that is definitely linked to serious lung disease. There are additional volatile compounds. There are heavy metals. And it's often younger people often feel that this is just harmless water vapor, which it truly is not. So the question always comes up, are vapes or e-cigarettes safer than normal cigarettes? Well, in a way, you could make the argument that there are fewer harmful chemicals than in a burn cigarette. However, there is a lot of emerging data coming out to suggest that the e-cigarette and vapes do lead to chronic lung disease, asthma, and there's repeated exposure to certain chemicals in the electronic cigarettes that are really not truly understood. I'm not going to spend a lot more time on this, but enough to say that they are just as addictive as cigarettes, and unfortunately, they are not approved by the FDA as a smoking cessation modality. So why is it so hard to quit smoking? The main reason is nicotine. Nicotine is a highly addictive chemical that affects the release of several neurotransmitters, specifically dopamine, norepinephrine, acetylcholine, all of which are involved in the pleasure, arousal, and cognitive enhancement pathways within the brain. The onset of nicotine when a cigarette is smoked is about 7 to 10 seconds when it reaches the brain. Again, it affects nicotinic cholinergic receptors within the brain, and it releases neurotransmitters that have significant psychoactive effects, all of which are positive. So it is a positive reinforcement system. Unfortunately, the brain develops neuroadaptation and tolerance with repeated exposure to nicotine, and the brain compensates to this exposure by increasing the number of nicotine receptors within the brain and the number of binding sites within the brain. So unfortunately, with the brain compensating by increasing the receptor and binding sites, when someone tries to quit smoking or has a brief period of abstinence, all of these receptors start to fire and become responsive, and then the resulting withdrawal symptoms set in. So again, cigarette smoke is very acidic. It is absorbed directly through the lungs. Light cigarettes deliver as much nicotine and tar as their traditional cigarette brands. Smokers will receive about 1 to 2 milligrams of nicotine per cigarette smoked. And as I previously said, it's about a 7-second onset from the time a cigarette is smoked to the delivery to the brain, which offers almost instantaneous reinforcement. So it's really a highly efficient and engineered drug delivery system, and nicotine is a drug. So what are some of the psychoactive effects of nicotine? There are certain psychological and cognitive effects that I have listed here, all of which are again very positive. So the withdrawal signs when someone tries to quit smoking are the exact opposite. You can have irritability, frustration, anger, anxiety, restlessness, insomnia. These symptoms usually peak in about 2 to 3 weeks after someone tries to quit, and they usually resolve after about 2 to 3 weeks. Some of the other symptoms, such as sleep disruption and increased appetite, unfortunately can take months to resolve. So now let's get into some of the treatment options. There are many treatment options available for people that would like to smoke. These options include pharmacotherapy as well as combined pharmacotherapy and other options. And I'll take some time to talk about all of these different options. It is very important to recognize that about 70 to 80% of smokers who are currently smoking want to quit. Unfortunately, 95% of those self-initiated efforts to quit smoking fail without some sort of treatment and intervention. The chances of success if someone wants to quit smoking are doubled if they use a medication such as nicotine replacement therapy, and it's been very well documented in the literature about the success of these programs. So some of the pharmacotherapy options, we're talking about medications now. There are 7 first-line medications and 2 second-line medications that I will not discuss that are not FDA approved. It is important to recognize that combination therapy using 2 types of therapy are far more successful than monotherapy alone. So I've listed some of the combination therapies which we'll talk about individually. So in our first-line medications, the treatment of nicotine dependence really begins with the selection of medications that can help the patients. Again, as I previously said, a single medication can be used. However, combining 2 medications with a different mechanism of action has a much higher success rate for that patient. So our options for monotherapy include medications that include nicotine, such as a patch, gum, sprays, inhalers, or lozenges, or using a medication like Wellbutrin or Chantix, which is very well known nowadays. All of these medications alone have similar results in clinical trials. However, again, they are not usually effective enough when used alone as opposed to when they are used in combination therapy. Combining the nicotine patch with another form of nicotine replacement. This is a common misperception. So a patient that has started on a patch can also be given a dose or a lower dose of a gum, a lozenge, a spray, or an inhaler to help with breakthrough symptoms as a first line for treatment. And Wellbutrin and Chantix both can be used as combination therapy with any of the aforementioned forms of nicotine replacement. These are the second line medications that I will not discuss. So how does it work? The other mechanisms, the other nicotine replacement therapies are used to help with the withdrawal symptoms and get the patient through that 2 to 3 week period that I discussed earlier to get them through that craving of nicotine. And it allows them to learn to live without cigarettes and without the distraction of cigarettes posed by the withdrawal and craving symptoms. So the nicotine replacement therapy, talking about patch, gum, spray, those all provide a medicinal or clean form of nicotine, which helps to reduce withdrawal symptoms and cravings. It can actually provide some positive effects and desirable mood, and it does replace some of the oral and handling aspects of the smoking habit. Again, as I previously mentioned, it is okay to use a nicotine patch in combination with a short-acting nicotine replacement, such as a gum. This gives a higher serum level of nicotine replacement concentrations, and it does help to decrease the withdrawal symptoms and helps to improve treatment efficacy. So if you look at the comparison of the gum, patch, spray, and inhalers, all of them have a fairly decent 12-week abstinence rate, but it is important to recognize that the compliance is highest when utilizing a nicotine patch. So our recommendation is to always start with a patch unless it is medically contraindicated, and then use the addition of a gum, spray, or inhaler to augment that patch to help manage any breakthrough cravings. This graph does show what the plasma nicotine concentration levels are when you compare the different forms of nicotine replacement. The yellow is a standard cigarette, and the patch is in red, the red box. And you can see that over time, the nicotine patch has its highest plasma nicotine level concentrations over time, which is obviously used as one of the most effective forms of nicotine replacement therapy. The two other medications I previously mentioned, bupropion is a medication that was initially designed to help treat depression, but has been found to be very helpful for smoking cessation. The mechanism of action is really not well understood, but it is felt to be a weak inhibitor of uptake of dopamine, norepinephrine, and serotonin. A lot of patients use this medication very successfully for quitting smoking, and they report that it does take away the desire to smoke, and that some patients even report that cigarettes do not taste as good when on this medication. And obviously, as I said, to repeat myself, it can be combined with other forms of nicotine replacement therapy. Varenicline, also known as Chantix, is a partial agonist that binds with high affinity and selectivity at the neurologic nicotine acetylcholinectic receptors. This medication, while works very well for patients that are trying to quit, does have some adverse side effects that are not very well tolerated by patients, which I will talk about shortly. In multiple clinical trials, approximately 1 year, 1 out of 5 patients who receive a 12-week course of treatment remain smoke-free on Chantix. Again, just to repeat, combination pharmacotherapy is much more effective than monotherapy and should always be considered. This compares the different forms of treatment using placebo versus bupropion alone, lozenge, pass, and then of course the combination of bupropion and a lozenge and a pass and a lozenge. And as can be seen, the success rates increase with the combination therapy. Some of the side effects of any of the therapy: the patch can cause some skin redness and dry mouth. The bupropion and varenicline both have similar side effects. However, varenicline, Chantix, does have some issues with insomnia, very bad, vivid, abnormal dreams, behavioral changes, agitation, and suicidal ideation. Combination therapy can, unfortunately, apply the effects of both medications on the patient, so they need to be watched carefully. And it should be noted that it is well documented that seizures are a potential side of bupropion, but it is only in about 1 in 1,000 patients, so very low rate of that. In terms of compliance, when you're considering the different forms of nicotine replacement, the frequency of dosing should obviously be considered, the side effects, the cost to the patient, particularly when looking at combined therapy, the access patients have to medications, as well as the preference and confidence, beliefs, and cultural considerations always have to be considered. The patch, again, does have the highest rate of compliance because it's fairly easy to use. Some of the considerations from a medical standpoint, specifically directed towards our primary care physicians, obviously cardiovascular disease, COPD, diabetes, and psychiatric comorbidities always have to be considered when considering any of these nicotine replacement modalities. Pregnancy is obviously a strong concern. The nicotine sprays, lozenges, and patch are a category D pregnancy contraindication. Moving on to some of the cognitive and behavioral treatment strategies that are available to patients. There are group therapies that patients often attend. These are nicotine groups or nicotine anonymous groups. The patients do benefit from ongoing group support and have the access to recovering peers who can reach out and help patients just have someone to talk to when they're trying to go through a smoking cessation program. These group therapies can also use cognitive and behavioral strategies that can be imparted to the patient and help them utilize that as an alternative for or in addition to their smoking medications. Additional treatment options include telephone counseling, which we have available through here in Massachusetts, QuitWorks and 1-800-QUIT-NOW. There are many new apps, both on the Android and iPhone platforms, which I've listed here. There are some online programs through smokefree.gov. Additional programs such as hypnosis, acupuncture, herbs and supplements, meditation, and yoga. The unfortunate reality of these alternatives, such as hypnosis, meditation, acupuncture, that there has never really been any randomized trials or scientifically proven data that they are completely effective in helping people quit smoking. Not that we would say they should not use these modalities, because a lot of people have had significant success with a combination of some of these various modalities. When we consider patients that are undergoing surgery, particularly in our department, we obviously would like our patients to quit smoking before an operation. And we usually tell the patients to try to quit smoking within at least 2 weeks of their surgical procedure. It does have a significant effect on an operation by significantly reducing the inflammatory state within the lung, and it obviously makes our surgery a lot easier, particularly from a lung standpoint. So our recommendations: quit within 2 weeks of surgery, preferably longer. Most patients, we tell them they cannot smoke in the hospital, so it's a good time to quit before they get into the hospital. And I've listed some of the medical benefits of quitting smoking prior to undergoing a surgical procedure, which I have listed here, and I won't go through all of them. And then what about putting a patient on a patch before they undergo surgery? Well, there's been overwhelming evidence to suggest that nicotine replacement therapy does not adversely affect and actually may improve many of the factors that lead to intraoperative cardiovascular complications. So our patients that do go on a nicotine replacement therapy, meaning specifically a patch, do very well with surgery. The one major drawback is there is a slight increased risk of altered hemodynamic complications, such as increased heart rate when they're on a nicotine patch. So in terms of our summary and take-home points, a large majority of patients that are currently smoking, approximately 70 to 80%, want to quit and would like to have access to a program or an aid to help them achieve smoking cessation. The unfortunate reality is 93% of these patients that try to quit on their own fail to do so. We always recommend multiple strategies to help our patients with counseling, nicotine replacement strategies, medications, behavioral programs. Always include multiple treatment options as opposed to a single intervention alone. Quit rates will improve if we as healthcare professionals provide support rather than just advice and warnings. Nicotine replacement products used alone or in combination are particularly useful and safe prior to surgery. Combination always increases abstinence rates. And a lot of the misunderstandings about nicotine replacement therapy and surgery have been disproven, and they can improve intraoperative cardiovascular complications. My final advice to patients is it is extremely difficult to quit smoking, not to give up. There are many, many support options for you in the community and through your primary care physician. And I would encourage primary care physicians to have open conversations with their patients and explain all of these options that are available to their patients such that we have a higher success rate for smoking cessation. Thank you very much.